the Center for eHealth Information Adoption and Exchange of the Patient-Centered Primary Care Collaborative. And today we will be hosting a webinar on IT and PCMH recognition implementation. Our speakers are Craig Brammer, who is the Deputy Director for the Beacon Community Program in the Office of the National Coordinator for Health Information Technology, Douglas Arnold, who's Executive Director of Medical Professional Services in Middletown, Connecticut, and Sean Lyon, a family nurse practitioner for lifelong care in New London, New Hampshire. This is an interesting recap of a very positively received session at the October 2010 PCPCC stakeholder meeting, but it was to a small audience. This was for those of you who may recall, there was a fire alarm just as the first speaker was stepping up to the microphone. And it took some time for the building to clear and be re-entered, and we had a substantially smaller audience at the reconvening. So while it was a very good session, we thought it would be a good idea to tee it back up. Of course, things have moved a bit, so the speakers are staying current. Before we jump in, I'd like to make a few opening comments. First of all, the Center for Health Information Adoption and Exchange is a center that's devoted to supporting the use of health information technology as it pertains to the patient-centered medical home. We actually have 3 of the 4 speakers today. The fourth, from the original session, the fourth, John Steidel, headed up a group that in 2010 published a very nice monograph on health information technology and patient-centered medical home use. You can obtain that through the PCPCC website, which is www.pcpcc.net. The second is that from a procedural standpoint, there are 2 things you need to know. The first is you can enter questions into your webinar dashboard at any time. There's a little button over on the right, and you can click it and type in a question. As moderator, I'll collect these questions over the course of each speaker's session, and then I will verbally give the questions to the speakers at the end of their talk. We will have question and answer following each of our 3 talks. That being said, I'll keep an eye on the clock so that we can have a wrap-up discussion, which itself can give opportunity for panel discussion and for question and answer. So again, the most important thing you can do is just type your questions into the box over on the right, and I will keep track of it. A couple of advertisements. Make sure that you register for the March 2011 PCPCC Stakeholder Summit. There are various postings of that, and you can find it on the PCPCC website as well. And lastly, there will be the January webinar for this particular center is on January 13th from 1 to 2:30 p.m. Eastern Time. And again, you can register, and we'll be going through the same process. This webinar is going to be recorded, and all the materials will be available, both the presentations and the slides, by the end of this week. So with that, I will turn the microphone over to Craig, and we'll have our first talk. And hopefully Craig is here. Craig was on a cell phone. I don't know if we lost him in the process, but if our webinar administrator can...
If you would like, Craig, if you'd like to maybe try to hang up and call back in with your PIN number, we'll maybe go ahead to another speaker in the meantime.
Okay, so we will actually, Doug, are you ready to tee up?
Yeah, just wait for my slides to come up.
Okay, so we'll do Doug Arnold first, and Doug will be discussing connectivity and how to securely share clinical information amongst a diverse group of physicians and small practices. So it looks like we're ready. Doug, carry on.
It's a pleasure to be on this webinar with everybody, and I hope we won't have a fire alarm during this talk. just a bit of background. I'm the CEO of a network of about 400 physicians in Connecticut, split roughly evenly between primary care and medical and surgical specialists. So the capabilities to support primary care and patient-centered medical home, the IT needs are really pretty important, and it's virtually impossible to be a functioning patient-centered medical home unless you have the adequate IT and also the connectivity that's needed. And there's a number of activities that have to happen in your office that you have to collect and store information, and you also need to be able to share that information and communicate with members of the care team, other physicians, and other clinical persons who are doing the case management, as well as to patients. And so the connectivity across the care spectrum and also getting patients involved is really an important aspect of a well-functioning patient-centered medical home. So you can see on this slide the things that in general are required. I will have to give credit to my colleague David Kibbe for putting this list together. But it's again, you can see it's important that you can store and manage the relevant patient information, and that can be done in a registry, in an electronic health record, maybe even in a spreadsheet. But you're going to have the ability to communicate with team members and share information. You're also going to need to report on the care processes and the outcomes and care processes and outcomes that are being done on an individual patient basis, as well as on a population basis for the entire population of patients in your practice. It may be by disease state, so you want to be able to report on all your diabetics, all your congestive heart failure patients, et cetera, and then to track performance and quality improvement. So how many of your diabetics, for example, have had both of their hemoglobin A1Cs and an LDL test and the diabetic retinal exam and whatever during the year, and be able to track that and identify which patients are compliant with evidence-based medicine guidelines, which ones aren't, so you can do outreach and be able to engage in decision support. And the decision support is really crucial as part of most EHRs have an ability to access decision support and evidence-based medicine guidelines for a number of mainly chronic illnesses, but depending upon the EHR that you're using, a lot of other things. You're also going to have to be able to collect relevant laboratory tests and other diagnostic tests. Be they, you might not need the actual images, MRI images or whatever, but you probably are going to want to be able to collect the clinical reports and the radiology reports as well. Also, it's crucial to be able to outreach to your patients and potential patients about what's going on with their care and the medical conditions that they've got. And there are a number of organizations that can help you do that. The first one that comes to my mind is Microsoft Health Vault. They're working with a number of federal initiatives and a number of healthcare technology companies to be able to do that. So your adoption of health information technology is really essential. And as I mentioned, you're probably going to want to be using an electronic health record system or a registry system. Many of the EHRs have built-in registries or registries that you can create to customize for whatever disease state or clinical circumstance you want to group your patients in. You also want to make sure that you have some kind of an e-prescribing package that you can collect their pharmacy benefit information and be able to access other pharmacy information and prescribing that's been done by other members of that patient's care team or other physicians. Some other things that really enhance a well-functioning patient-centered medical home are the ability to do, for example, online scheduling and same-day scheduling, electronic patient outreach, so you can either send emails to your patients that they're going to, dear Mr. Jones, you need to get a, you need to come in and get, or go to the lab and get your hemoglobin A1C test, and also have the ability for care management to reach out directly to your patients. The ability to order labs and pharmaceuticals, and the ability to share information across the care spectrum is one of the real challenges. I'm sure most of you are aware that within the meaningful use guidelines that there are, I think it's guideline number 12, which is the ability to share information across among a care team. And if you're not, if you're not connected to a health information exchange or some other type of hospital-based system or a state HIE, you're going to be challenged to share information, because, as everybody or most everybody knows, just because you have an EMR doesn't mean that you can talk to other physicians or other members of the care team that may have EMRs or not. So there are a number of aspects that are working on that, which I'll get to in a second. For assistance on those practices that may want to get to to patients in their medical homes, some status of that, and have not made a big investment in health information technology, there's a number of programs out there to assist you. The first one is, in every state, and in some of the big states there are more than one, but every state has a health information technology regional extension center. And for example, in my state, in Connecticut, you can get up to $5,500 in services to help what are called priority primary care providers, which in this definition is family practice, internal medicine, pediatrics, and OBGYN, and the excuse me, the practice or physician assistants and APRNs that may work for them, to help you select, implement, and get to meaningful use of certified health information technology in EHR systems. There have been dozens of EHRs that have been certified already. Those are available on the ONC website. I'm sure everyone has heard about the federal incentives for meaningful use for certified HIT. The final regs for how to go on and certify are still waiting to be issued by ONC. They should be up shortly on their website. But the qualifications, if you meet meaningful use, you can qualify for up to $44,000 per physician from Medicare, or over almost $64,000 from Medicaid. Also, a number of hospitals and healthcare systems are providing substantial financial assistance to physicians and practices to help them adopt HIT through their stock provisions, where they can help you with up to 85% of the cost on those. Regarding the options for health information technology, this is a rapidly, almost daily evolving landscape out there. It's really important to try to keep up on what's happening with the technology. There are mergers and companies buying up other companies, and it's just getting quicker and quicker. Just in the last couple of weeks, there have been some major announcements of companies merging and being acquired. Some of the health plans are getting into the HIE business, and but it's important that if in your decision about what EMR or EHR to buy, there are a number of things that you may want to consider. Most of the older, larger, what I call the big iron EHR companies, many of them still use client-server technology, which requires a server in your office or off-site, and the software to be loaded on all of your machines. Pretty expensive, and usually requires in-house tech assistance. There are a number of other EHRs that are moving to what they call the cloud, where the software resides on the internet. and you can access it through any internet connection, either on your laptop, your desktop. Some of them are even available on your cell phone or PDA. There's also another substantial option, which is also growing in breadth and depth, which are the modular health information technology components, a lot of which are interoperable. So you may see, for example, a patient registry that's interfaced with a e-prescribing, that's also interfaced with maybe a SureScripts tool and lab interfaces, so that you can access lab information and also do patient outreach. There's a lot of developments happening in this area as well. Quite often these modular components are much more cost-effective or don't require such a substantial investment as are required by some of the big iron, what I call the big iron EHRs, which can end up being tens of thousands of dollars per physician per year. Important to the notion of patient-centered medical home is that it's really a team sport. Within your office, in your practice, you're going to have physicians and physician assistants and nurses, and maybe your business office people are all going to be involved in touching the patient one way or another, outreach to the patient. And it's really important that the members of that care team have regular communication and ability to exchange information within your office and outside of it on what's specifically going on, because a really high-functioning patient-centered medical home practice is looking across the care continuum and trying to do a lot of proactive management, especially of chronically ill patients, to avoid unnecessary hospitalizations and ER visits. Your adoption of health information technology, unfortunately, doesn't guarantee that you're going to have an ability to exchange information, especially across practices. So if, for example, you've got to refer one of your patients to another practice, a specialist perhaps, just because you have eClinicalWorks, for example, and the whatever specialist cardiology may have NextGen or Allscripts or another one of the systems, those don't necessarily talk to each other, and that creates a pretty substantial problem. There are some options for secure exchange of health information. Excuse me. Many state and local health information exchanges are coming up. However, a lot of there's a big ONC grant program to each state to develop state HIEs, and those are in various levels of functionality or getting together. There's still a lot of work to be done. A number of the big EMR companies have established what we call in the industry walled gardens, of where you can exchange information easily with other users of the same EHR package, but you may have a more difficult time exchanging information with practices that don't use that EMR. And the thing I want to get to more directly are the emerging standards from what used to be called the Nationwide Health Information Network Direct Project, and which has been rebranded in the last month or so, the Direct Project. And the Direct Project is something that I've been participating in for most of this year, and there are a number of work groups through it's an office within the Office of the National Coordinator for Health Information Technology, which is referred to lovingly as ONC. And the Direct Project is a project to develop the specifications and addressing components, whatever, to enable secure and scalable transport of health information, including encrypted health information to known trusted recipients using the internet. So, for example, if you have, let's say in our practice, we've got eClinicalWorks, and we need to send a care summary of what's going on with Mrs. Jones to the cardiology practice across the street that's on Allscripts, using the direct protocols, you would be able to do that. The Direct Project has been going on for most of 2010, and it's been a very, very interesting collaborative involvement of literally dozens and dozens of individuals representing provider groups, state HIEs, health information exchanges, HIT vendor groups, and they've really been working quite hard. There's a number of work groups to develop the transparency and access that's going to be required to exchange information. So the Direct project will enable the users to be able to meet the interoperability requirements to meet stage 1 of meaningful use. And there are a number of pilots that are being brought up right now. There are 6, and I think just another one got added this week that I didn't include on this slide. So there's the Rhode Island Quality Institute, which is also a Beacon Grant recipient, and those of us who aren't are quite jealous of all the money that they've got to do that. My group, MPS, the Med Allies, which is a large physician network in the Hudson River Valley of New York, CareSpark in Tennessee, which is also the Tennessee Health Information Exchange, the Redwood MedNet in Northern California, which is being headed by a guy named Will Ross, and Vision Share, which is a health IT company out of Minnesota that's working with public health agencies in a couple of states. And then the newest one that just came up is with Christus Health, which is a Gulf Coast-based hospital network down in Texas. That's being headed up by a colleague of mine named Hank Fonberg. And so and our goal is to, within all these pilots, to enable and to demonstrate the usability and feasibility of using the NHIN Direct protocols to exchange information. So just to give you an idea, in our pilot project, who's participating, my group, again, of over 400 physicians. We've got Quest, which is a national lab, and their IT subsidiary, MedPlus, which is going to serve as the term is HISP, the Health Information Services Provider. We've got Community Health Centers, which is the largest federally qualified health center in Connecticut, Middlesex Hospital, the Sonicare, which is the largest home care provider in the state, and a few more technology partners, DocSite, which has now been purchased by Covisint, and they have a very highly regarded registry program that dozens of our physicians have been using for years. eClinicalWorks, which is one of the largest EMR vendors. And then Microsoft Health Vault is participating with our project and a number of other ones to enable, to involve the patients so that physicians can push health information, lab results, care summaries, whatever, out to patients, again, and there are aspects of the meaningful use requirements that cover that. We're also being supported by some of the IT folks from the American Academy of Family Practice and Dr. David Kibbe from the Kibbe Group, who is a family physician and a very skilled health technologist in his own right. The Direct project has set up a few what they call use cases to cover. What circumstances are we going to try to address in sharing health information? And this relates directly to a well-functioning patient-centered medical home practice, where you're going to have to send and receive messages and health data out to specialist physicians and other care coordinators, and be able to get that information back. You're going to have to be able to send reminders for preventive care to patients, come in for your tests, come in for your mammogram, whatever. You're also going to have to be able to provide, as part of meaningful use, clinical care summaries to patients about their visits and other health information. You're going to have to be able to electronically receive lab results from one or more labs, and then also be able to submit immunization and other syndromic surveillance data to your state public health agencies and maybe even to the federal government. And then you're also going to have to be able to integrate with other HIT systems because, as I said, you're going to have, in most communities, you're not going to have a situation where there is just one EHR being used by a huge number of docs. It's akin to a lot of other markets where there are multiple products, and the EMR that may be good for a small family practice with 2 or 3 physicians might not be the one that that a large specialty practice that's getting referrals from a wide area of primary care physicians would necessarily want to use. So the whole purpose of the NHIN Direct project, and the Direct project as it's been called, is to enable the point-to-point email and exchanging of information, structured data, and the like, continuity care records, continuity care documents, to be able to access that. These are a couple of the slides from the Direct project website, and the threats of the current system are that it's not sustainable, and that we're going to need to substantially train a number of clinicians on how to exchange information. And I won't read this slide up to everybody, but there's a number of strengths that are being assessed in the Direct project, and I think that what you're seeing is already a few dozen health IT vendors and EHR companies have committed to embed the Direct protocols into their system to facilitate the sharing of information across from point to point, from end users, be they clinicians, members of the care team, or patients themselves. And so this is my last slide. So what are you going to need to implement Direct? So far, the first thing you're going to have is you got to have a connection to the internet, and you're going to have some kind of email client software, whether that's Outlook or some kind of email that's not something that just sits on the web that you have to access to receive your emails. It has to be a direct email client. And you're going to have an account with a health internet services provider, which will give you your Direct project address and to manage the security that's complying with HIPAA. And so if you've already made an investment in EHR technology, you probably want to check with your vendor to see if they're planning on embedding the Direct protocols into your system so that you can facilitate the exchange of information. The NHIN Direct project is going to have some real value because it's going to enable low-cost, efficient exchange of information without having to wait for state or local health information exchanges to be brought up. And so I urge everybody who's interested in having a well-functioning patient-centered medical home to go on to the web, look up the Direct project and within the ONC website, and take advantage of the capabilities and the assets that are being built by this great team of folks working on it. That's the end of my presentation. I appreciate your attention. I'll be happy to take any questions.
This is Jim Crawford. One comment just quickly. I've got a couple of chat room people who say that the audio is cutting in and out. On the telephone, I've had a good feed. I don't know whether the issue is one for the web-based microphone and speakers, but I put in a query.
If you're having any audio issues, we are recording this conference, and it is fine on the phone line, so it'll be available online at pcpc.net/media tomorrow, the full video of the presentation, if you do have any audio issues, but it should clear up.
And so if I understand that correctly, the telephone line does seem to be hanging tough here. So another couple of questions came in. Will the slides be available for downloading after the webinar is complete? They're going to be posted to the website, and perhaps our organizer can tell us whether the slides are downloadable once they're there.
Yes, so they're all downloadable along with the presentation, the video of the presentation, one day after, so tomorrow by midday.
Yeah, Lauren, are you going to put those up as PDFs?
Yeah, they'll be as PDFs.
Great.
The third just procedural question is just to repeat the PCPCC website. So it is www.pcpcc.net. Again, pcpcc.net. And there are all kinds of materials you can download there. I hope you enjoy browsing the site. Okay, so Doug, some questions have come in. First, can you achieve patient-centered medical home designation level 1 without health information technology?
Well, I don't have the NCQA regs right in front of me, so you'll have to forgive me for somewhat sliding on that question. I think that in general, if you want to be a well-functioning patient-centered medical home, you really cannot do it without having some level of health information technology, be it e-prescribing and a registry, or an EMR. But I think it's somewhat of a fool's errand to think that you can do that we're almost in 2011 without involving using healthcare information technology. And one of the reasons why I wanted to stress in my presentation that the regional extension centers are that grant program is available precisely to help small primary care practices make that switch. And there's a lot of help to help you pick something that you can get one of these systems that can be incredibly functional for under $200 a month per physician. And there's some really great systems out there. This is a rapidly evolving technology, and prices are coming down substantially. And so some of the old war stories of spending tens of thousands of dollars on software and hardware may not necessarily be the case. And so I urge everybody to if you're really serious about becoming a patient-centered medical home, to make that investment in technology.
And actually, in 2009, maybe the answer would have been you can achieve level 1 without health information technology. But I think Doug has given us a nice soundbite. In 2011, it's kind of a fool's errand. Second question: where can we find meaningful use guidelines?
Oh, the meaningful use guidelines are on the HHS website, and I know they're in ONC. I will be happy to send off a 2-page Word file that I prepared from some things that David Brailer, the head of ONC, had put up, and I think that. But you can find that stuff on the internet very easily.
Okay, third question. Are pediatricians included as priority primary care providers in Connecticut?
Absolutely. Pediatricians, family physicians, primary care internists, as well as OBGYNs. That's the definition of priority primary care providers for the REC program nationally.
So, Doug, if you can keep your questions short, because actually a whole bunch of, your answers short, a whole bunch of questions have come in. Can you define and clarify what is meant by certified HIT solutions? Does this mean practices must have an electronic medical record?
Well, I would urge you to go on to the ONC website, and there is a page, or more than a couple of pages, which specifically reference the certification progress or program, and vendors and products are being certified virtually daily on that. And so to go in and see what's been certified, there are certifications for modular as well as complete systems.
Next, just a point of clarification. One of the listeners pointed out that CareSpark is not the statewide health information exchange in Tennessee. Axolotl is the statewide HIE. So we can just make note of that. A bunch of questions have come in regarding direct, and I'll try to dig them out. The first one is, does use of direct conflict with the health information exchange agreements in your area?
No, they are supplementary.
Next question, will the direct project networks replace the need for buying a patient portal from the EMR company?
They very well could. If you have a connection with for example, Microsoft Health Vault, you may not need to purchase the patient portal within your EMR. But I would say that in general, but that there may be some specifics that may change some of that regarding what vendor you're using.
Third question related to direct. How are the direct project transactions harmonized with health information exchange activities in the community, which are implementing standards to overcome different EMR situations?
That is a very good question, and that's something that the policymakers in Washington are dealing with virtually as we speak. There's a hope that that they can become supplementary and synonymous, but there's still some policy issues and some technical IT aspects to get worked out on that.
You really caught the curiosity here with Direct. What is the timeline for implementing Project Direct?
Well, the Direct project is the 6 or 7 pilot projects are going to be starting. A lot of work has been gone in already on them. We're hoping to bring ours up, for example, starting by the middle of January. The Direct protocols just got finalized a few weeks ago. So this is really an ongoing activity, but we suspect that by the middle of next year, that a substantial number of vendors will be implementing and including the Direct protocols in their software systems, which will allow the exchange of information directly over the internet without having to be forced into a walled garden HIE or something like that.
Okay, well, there are more questions, but I think we're going to have to move on. Thank you very much, Doug.
And if you'd like to, I'm happy to talk to people offline if you want to send me emails or whatever about Direct or anything else.
What is your email, Doug?
It's darnold@mpsphysicians.com.
darnold@mpsphysicians.com. Okay. Craig, are you on the phone?
mpsphysicians.com. Thanks so much.
Craig, are you on the phone?
I am on the phone.
Excellent. Okay, so Craig, fire away.
Terrific. Thank you all for the opportunity to talk a little bit about some work at ONC. This is very applied work, and again, I appreciate the chance to just have this conversation. The last time at the Washington meeting, I stood up, and just as I was introduced, the fire alarm went off, and I'm used to people getting up and leaving when I stand up to speak, but it's never happened quite that quickly. The room totally evacuated. So anyway, an opportunity to do this again is terrific. I wanted to talk a little bit today about the Beacon Community Program, which is unique to ONC. If you think about all the activities of the Direct project that was just described, the regional extension centers, the state-based HIE programs, our policy and privacy and security work, et cetera, all that really is spread across the nation like peanut butter. Every part of the country is covered by a regional extension center, a state HIE program, et cetera. The Beacon program is unique in that we like to define communities in the country that had demonstrated an aptitude and a trajectory towards more advanced use of health information technology. Communities that had a higher than 40% EHR adoption rate, for example. But equally important that they had a history of working together across multiple segments of the health sector toward common improvement aims. So this was a rigorous competition. There were over 130 communities applied for the first round. For the second round, we only had 2 slots and had over 100 proposals. And I have to tell you that these proposals were very strong. We were only able to select 2 in this second round, but I would say at least half were really compelling projects. So it's important to note that while we're focused on 17 communities at the moment, we have great confidence that there's terrific work going on across the nation. The examples that you heard just before the prior speaker, for example. So just a snapshot into America and where what communities are doing is what the Beacon project provides. Next slide, please. So what are our aims? Our aims are to build and strengthen the HIT infrastructure in regions and really demonstrate the effectiveness of health IT. the Americans who are paying for the HITECH Act at an average of about $100 per person, it turns out they're not terribly compelled by adoption rates or by how many electrons you can sling around their neighborhood. What they really are interested in is improvement in quality, cost, and population health. So again, Beacon is about bringing together all the HITECH Act in specific communities to demonstrate actual improvements that people understand and can appreciate. Secondly, we aim to really learn from these communities and understand what lessons they're learning and share that more broadly. So later on here, I'll talk about some of that work about getting out the lessons from these sites so that other communities can learn and follow suit. Next slide, please. So at the end of the day, this is not just about technology. We talk a lot in our work about the tribes of the health sector, and there are the quality improvement tribes. These are the folks who are all about applying industrial methods to the health sector, the Lean Six Sigma guys and the measurement folks, and they're all this week probably in Orlando at the Institute for Healthcare Improvement conference. These would be the Berwickians, if you will. There's another tribe that are the payment reformers, and these are the folks who argue that if we shift from purchasing volume and more toward value, that the notion is you get what you pay for. A lot of activity on the payment reform front at the moment, of course. There are the consumer zealots that are all about transparency, getting quality and cost information out to consumers, getting perhaps consumer-directed health plans underway, but somehow getting consumers more engaged in purchasing. And then the IT, the wirehead guys, the folks that I hang around with, that if we could just wire the health sector, surely things would be better. Well, Beacon, as a matter of fact, is about all of that and more. It's about using IT as a platform for care delivery, innovation, for measurement and provider feedback, to support payment reform, accountable care organizations, et cetera, but all in service of improvement in quality and efficiency. Next slide, please. So here's the list of the Beacon communities. These are 17 communities across the country. And actually, you can go on to the following slide, which is the map of the United States. This actually is the way it shook out. We were quite surprised after a very rigorous objective review process, really a wide dispersion across the nation, a lot of variation regarding geography, but also population of focus and demographics and clinical targets, et cetera. The thing that was compelling to me and our team, frankly, about the Beacon program, the reason we chose to join the team was the inherent humility in this particular project. Within the DNA of the project is this notion that the real work happens out in America, where people are actually got their sleeves rolled up and are setting about doing this work, where leaders are coming together saying we're tired of the status quo and ready to work together to achieve common aims. So our first initiative was a first working relationship with these communities was to say, more specifically, what are those aims, and to actually build out a logic model, which is described in the next slide. This was a rigorous 90-day process that began first not with describing technology, but with describing what are your community goals and what are your outcomes. So this is on slide 6. You can see through this 90-day process, the communities came together to more clearly articulate their aims and performance measures. Second, they went through the process of defining the activities that they're going to pursue, what would be the outputs of those activities, and what are the resources required, federal investments as well as other local assets to produce those outputs. And finally, the last leg of the process was risk identification and mitigation strategy, and beginning to work towards sustainability, both in terms of business model for exchange, if the exchange is the core of their project, but also thinking about how health IT fits within payment reform environment, and what is the regional architecture that's requisite for a payment reform community, an accountable community, if you will. What is the technology solution that competing providers might choose to cooperate on and commoditize versus what is the technology that needs to be housed best within individual delivery systems. So some of those shared assets are exchanged, but also aggregation of data, analytics, et cetera. We can talk about that if there's interest. Next slide. So our work with these groups is very aggressive. I just want to mention that we have a technical assistance team that is comprised of Booz Allen Hamilton, the Brookings team, and the Institute for Healthcare Improvement. And so with those latter two members of the team in particular, you can appreciate that that this is an ONC project, but it has a strong healthcare improvement practice redesign kind of flavor, as well as a payment reform flavor brought by the Brookings team. Next slide. So we have a lot of communities that are very involved in PCMH, and thinking through again, how do you leverage technology as a region to support medical home initiatives. So in Grand Junction, Colorado, for example, there's been in the whole Colorado region, as folks may know, there's been a lot of work around patient-centered medical homes. So how does that work leverage their health information exchange, which just celebrated its 5th-year anniversary a couple weeks ago? What is the intersection between these two, the IT tribes, if you will, and the practice redesign and payment tribes? And so in Grand Junction, we're seeing terrific work where these folks are coming together to leverage the exchange for a more comprehensive view of the patient, longitudinal view. We're seeing communities working on more streamlined referral and care coordination protocols across markets, even across competitors. A lot of work around CDS and optimizing EHRs to support decision making. A lot of work around data aggregation and performance measurement. This is an area where communities, even with well-established exchange organizations, historically have largely been around messaging, and now that their stakeholders are looking to them to do more in terms of aggregating data and providing more sophisticated analytics. So Indianapolis, for example, is a beacon community that is a national leader in exchange and has been doing terrific work in the past couple of years around data aggregation and analytics. They are, Indianapolis is one of the 2 Medicare 646 quality demonstration programs, and use clinical data and administrative data from Medicare and from commercial carriers to do analytic work. So the Beacon program in Indianapolis is about taking that work to scale to a larger region, from a 9-county region to a 41-county region. So it's going wide, but it's also going deeper. So much more sophisticated analytics, actuarial analysis of data to identify improvement opportunities, much more robust support for care transitions, and making sure that results are delivered and discharges that are delivered from a hospital via an exchange to a practice that there's a catcher on the receiving end that has workflow redesign in place to make use of that information about a recent discharge. So what are some of the examples, again, of some work? A physician in Cincinnati, Ohio, a Beacon community, Doug Mangenheim, is a solo doc. He has a nurse practitioner and a highly optimized practice. Dr. Mangenheim tells a story of a patient of his that had a concerning mammogram, and they decided to do a second mammogram, and he knew that she was worried about the results. He called her and gave her the good news that everything looked good. And she said, Dr. Mangenheim, I'm surprised you called because I've not yet left the parking lot of the facility. That result was read. It was delivered through HealthBridge, the Health Information Exchange, directly into Doug's EHR, and he happened to be there at his desk and picked up the phone and called her. Now, that doesn't happen in most markets in America. The beacon communities are those markets that have the capacity to do this kind of work, and again, our aim is to accelerate it. The beacon program is, like many of these ARA-funded programs, is a short-term project. We don't expect communities to stand up a whole new set of a whole new project. Rather, we aim for them to use this opportunity as an accelerant to take them from where they are to where they want to be faster, and again, to glean those lessons and share it with others, like many of you on the call perhaps who aren't in a beacon community at the moment. So what are some of the questions we're wrestling with? Again, what is the requisite information architecture to support multiple ACOs or medical homes within a given community? Our team is working very closely with CMS and the Innovation Center in particular. Several members of our team are on the ACO planning committees and are detailed over to CMS. So really trying to pay attention to this, the nexus of the health IT and payment reform agendas, and making sure that these are moving forward in concert. You know, we're really working on, just got off a call this morning on this analytic models, and again, this is complex work. These are these exchanges often have many vendors that are involved in their work, and so it's about how do you bolt on analytic infrastructure, be able to really identify patients and begin to look at populations within a community, be able to segment that by provider, to do leakage analysis where, you know, in an ACO world, the Dartmouth folks estimate that within any given sort of a typical ACO, patients would likely receive care 30% of the time outside the walls of that formal ACO. So other providers, the patients that are attributed to the ACO, you know, aren't restricted. And so a lot of analysis will be needed to identify how that's, how do providers manage that that population without an assignment function. And so, so again, building out this infrastructure to look as a community, as a region, as a health referral region. And lastly, how do we ensure that the lessons that we learn are shared more broadly? I want to mention a new initiative. As folks may know, there are several programs in the country now that focus on regions. One by the Robert Wood Johnson Foundation, their flagship initiative, Aligning Forces for Quality, focuses on also 17 regions in the country. There are 4 overlaps with the Beacon program. ARC is doing a lot of work with regions. The good news is that I think there's a strong sense that real healthcare change happens in local communities. And so our aim as program leaders for these various programs is to begin to make sure that our work is aligned and that we're don't have just a lot of sort of isolated projects. So to kick that off, there's a new health affairs blog. I believe it's going out today or sometime soon by Dr. Blumenthal, Dr. Rita Lavisa-More, who is the CEO of the Robert Wood Johnson Foundation, and Carolyn Clancy, who directs ARC, announcing this tighter working relationship. And there's actually a site that you may want to jot down called The Transformation Has Begun. So there's the transformation.hasbegun.org. You can go to this site and just pitch in your comments. It's just an open site for looking for feedback from the country in terms of what's helpful to local communities. We don't know what to expect from this. We're hopeful that there will be a national dialogue that can help guide us in terms of how we go forward. Again, we at ONC are really keen on working with these 17 communities, but if you think about that list of applicants, we're also equally interested in communities number 18 through 50, and how do we support them as well. And so there's a lot of work underway in that regard, and we hope to be unrolling some opportunities in 2011. So with that, why don't I stop and see if there are any questions. Again, Beacon is just one opportunity to identify some communities, just a cohort of communities. There are many across the nation, but that are leveraging IT in service of improvement in quality, cost, and population health.
Okay, so this is Jim again, and several questions have come in. Is there an agency focused on optimizing electronic workflow in the patient-centered medical home?
Is there? I'm sorry. Can you repeat the question?
So, is there any agency focused on optimizing what this questioner asks, electronic workflows in the patient-centered medical home model?
Yeah. So there's not a particular a particular agency that owns that topic, but there's a lot of work in many federal agencies are doing more on research and evaluative and best practices perspective. The Center for Medicare and Medicaid Innovation at CMS, recently announced their patient-centered medical home, their variation of that in 8 states, and a lot of that is about learning networks and identifying best practices, et cetera. So there'll be a lot of work there. We at ONC do a lot of work around workflow redesign as well. The military, the DoD, and VA are doing a lot of work in this front. So it's not nested within one particular agency, but sort of spread across many.
Comment before the next question. The comment is the importance of not leaving behind the patient population as we move into the IT and health information technology era. I can put in a little plug here that several of these webinars in 2011 will look at issues of patient accessibility and IT literacy. So yes, this is an important topic for those who've been thinking about this. Back to the question. Craig, do you see the federal government standardizing IT infrastructure design in the near future? And I don't know whether it's yes, no, it'll happen, or the near future part of the question. There's sort of two questions here.
Yeah, or the architecture question. Well, of course, a lot of the work around ONC that was referenced earlier is around standards. So, arguably the most important thing the government can do is establish standards and then let the market run with those. We want to get to the point where the conversation, when you're looking at a particular vendor, the conversation is not about, the pitch is not about we interoperate well with this particular product that you already have. We want that conversation to go away. We want it to just be assumed that interoperability is just part of the standard package, and that standards are the basis for that.
Okay, next question. Do you see the 800-pound IT players entering and dominating the IT space through acquisitions?
I'll refrain from commenting on that. Folks, I'm sure, are aware that there's a lot of movement in the market at this point.
Okay, perhaps an easier question. Has Beacon done information exchange with the Department of Defense to promote the patient-centered medical home? You've already mentioned the armed services earlier. We
have 1, 2, 3 beacons that are dealer sites, and that's the joint project between the DoD and VA. I happen to be in San Diego right this moment, and this was the original test site for the dealer where there was a patient, an older veteran who had sort of gone both into the VA and DoD system, and yet those systems historically have not been interoperable. And so a terrific story about how he had medications and clinical indicators that in both systems in their electronic records, but clinicians on either side of that fence weren't aware of. So there's more of that as service members are coming in and out, switching from those two systems more and more. There's increasing movement toward dealer being, in particular, connecting those two systems.
Okay, one last question. Yes, no. Do you see the patient-centered medical home model being mandated anytime soon?
I'm not aware of any mandate.
Okay. All righty, Craig, thank you very much. We will move to our final speaker, Sean Lyon. Sean, fire away.
Well, good afternoon all, and I'd like to start off by reiterating the focus of this conference that we're doing right at the moment, which is focusing on successful IT and the patient-centered medical home implementation. And with that, recognizing that my talk is focusing on this as a nurse practitioner as well as a rural practice with less than 5 providers. And that's quite different on 2 measures, one being we are a nurse practitioner autonomous clinic with 3 nurse practitioners having achieved level 3 as an NCQA level medical home, as well as being out in the rural areas, having such a small number of providers. Most folks, I think, on the phone and in this process are working in much larger facilities. So filter what I have to say, please, from that perspective. With that being said, I have some great gratitude for everyone who's been involved in helping us with this, especially after the wonderful invitation to speak in D.C. last month. I guess that would actually be 2 months ago at this point, because there seemed to be a host of curveballs that we have in this whole process for all of us when we're going through implementation. My most recent one was returning from the NCQA Health Policy Conference last week to a house full of soot, lucky to have not lost our dogs or the house. So I'm sitting here at the moment hoping that the other shoe doesn't drop for me or any of my friends. And with that being said as well, recognizing I have some great gratitude for all those who have come before us, whether in Pennsylvania and the NCQA recognized medical home down there for nurse practitioners, as well as the other ones in Oregon and New Hampshire. So I'm going to see if the slides are working just great for us. We're going to move on. I have control, I believe, on the slide set. So focusing on who we are as a nurse practitioner independent practice clinic, it's helpful for you if you recognize the 14 states around the country where nurses are in advanced practice working autonomously, whereby we have full prescriptive authority. We have the full role of assessing, diagnosing, treating, and developing a plan of care. And that plan really follows a PDSA model in our training, where we're developing, implementing, and certainly going through the evolution for care for those patients. And certainly it's a process of working as a member of a team. What I'd like to make sure you understand as well is how did we get to where we're at in implementation, as well as focusing in the greatest part on what are those outcomes, so you can see that you can do this yourself as well. When you have these slide sets yourself, please feel free to click on the 4 blue areas here so you can see some of the details through our web links and get some more details regarding our clinic.
That may not happen since these will be PDF files, so the links may or may not work.
I believe when you're in a PDF, if you right-click,
okay,
it should take you into another slide to do a hyperlink.
Excellent. Okay, good. Sorry for that.
That's great. So my background working in community health, and it's really neat to see the Beacon community out in Spokane. I worked there many years ago prior to this. Our mission flows in the same way as many others, in that we develop this from our hearts. And as you'll see here, is our mission is one not just of health. With the mission, and we developed our vision to go with that, focusing on our history from its inception back in '03 when Kitty Kidder formed the practice, and the idea of creating a place of safety not only for the patients but for the employees as well, and to build from that place of safety in order to allow for the full spectrum of health to be granted. Sorry, I'm having a little bit of trouble with these slides, going a little, okay, so we can. So our values flow from some very specific aspects of our mission. With the safety, we really want to have an experience that's feeling safe. Nursing is just exactly what we do. and it's nothing more than that. Confidentiality is the essence of the experience. Individuality we focus on in terms of each patient one at a time, and that's certainly Berwickian, as many of us joke. And time is in the essence of that individuality, so that we work in that moment. And the reason it's important to go through these, I think, at this point, is recognizing that as NPs, we are not following strictly a medical model. We try to work within the nursing model. Therefore, seeing that we have a team here of professionals from a variety of skills, but all of the basic aspects of what would be required. And what you'll see here in these pictures, this is from our pediatric room, the handprints from the kids. And if you're looking close, you'll see Butch and Tuppy there on the side of your screen, our mascots, one of the cats and dogs of our patients. The slide that you have here as well focuses on the individual aspects of a medical home in terms of some of the simple little things that creates that place of safety. Obviously, those handprints in terms of the engagement and ownership by the kids, toy box where folks can play, messages that are continuously personalized and sent out to families. So the big question really ends up being, well, okay, so how did we do this? How did we get there? And in order to get to that point, I really want to point out two stories for you. One is a patient who came to us who transferred whereby we had no prior information through electronic records as to what had been happening. He had been transferred from Dartmouth up to Burlington, down to Boston, and made his way back to us. Severe spinal stenosis, multiple surgeries after a diving accident in Tennessee, and when he comes into the door, we were just out of the water in terms of not having any information. Therefore, we were doing the same thing as the specialist in Boston, was trying to avoid duplication of information being gathered, and yet having to wait to gather that information. Contrasting that with a patient that we knew well had transferred out and came back to us, we had obtained the electronic record access into the Dartmouth system and others prior to his arrival, so that when he came in with the alpha-1 antitrypsin deficiency, the hep C with failure to treatment, the low platelets, which means he couldn't have the spinal fusion taken care of, and his substance abuse history, which was questionably operative at that point with poorly controlled depression, and the COPD, which wasn't being treated, had a whole host of problems, and we were immediately able to get him connected with behavioral management, substance abuse, a variety of medication interventions, simply because we had that HIP access and the information to go with. So you can see from the get-go that we're great supporters of the HIT to be able to make it happen. As we decided to move into the medical home model specifically and to work toward this, we recognized several deficiencies that we were going to need to overcome as well, and hoping that this process would be helping. Certainly patient education competency was something we couldn't easily measure. Care coordination has been and remains a challenge for us, in that interoperability with a variety of providers throughout the region just hasn't come to that level yet. We are in the process of converting to a patient portal, and hopefully that will be started in January so that patients can get into it, their medical record and prior records as well. We have been able to see the transferring of email from patients into our electronic medical record and other aspects of the meaningful use that we have confirmed. So in order to move into this, we had a two-step process with the Citizens Health Initiative, as well as the funding and support through the payers in our area. The Center for Medical Home Improvement, please note the links here, and avail yourselves of those, and they are referenced as well in the book that was mentioned at the beginning that PCC has put out on health IT and the patient-centered medical home. The Center for Medical Home Improvement did a gap analysis to let us know where were our weaknesses in the process. And this gap analysis and the CAP framework is one that's available to all of you as you're trying to move into a patient-centered medical home, as well as evaluate yourself in the evolution of the work that you're doing, and strongly recommend you consider doing that. And in that process also, thanks certainly go out to the New Hampshire Endowment for Health and their support in that process as well. So we begin to ask, well, what is a medical home and what are the high-quality teams? And we had to identify those challenges in order to achieve that. On one level, we're trying to get to a model that is the NCQA model, and yet we are also trying to go about this as nurse practitioners, which do not mesh entirely with that NCQA model. So what we came up with was a blending whereby we first had to be true to ourselves and true to our patients, and then document. So we focused on what it was that was truly ourselves, and with the help from the Center for Medical Home Improvement, we tried to document what it was about ourselves as part of our quality improvements in terms of improved communications and very strong collaboration. The organization of that clinical information is pretty straightforward, which most of you have seen already. Obviously, we have the EMR available. We've had registries focusing on the New Hampshire multi-stakeholder goals of working on the coronary artery disease, congestive heart failure, and diabetes. We've added in our own areas with asthma, and the most interesting registry aspect is the high-risk patient, and that goes back to the team concept whereby any member of the staff will define someone as high risk. And that is not only just a gut reaction, but obviously otherwise in terms of uninsured, homeless, and the obvious other ones. With the organizing of the clinical information, we've continued with e-prescribing, focused with care management, and the web-based access for our patients. So moving into the areas of some data, I think it's helpful for you all to see we are in some ways relatively strong with our commercial base at 69%, Medicare at 23%, and otherwise as noted. This is a simple example of a patient survey that we used, recognizing this really follows with what we heard at the national, the NCQA conference this past week relative to the need for patient feedback cards, because much of what we get in patient satisfaction surveys is an answer to a question based on what we want to hear, and we're not necessarily getting comments. And so this was helpful information, but what we will be moving more for is what you'll see are the comment cards that will be in the back of that book that was referenced. So this slide is showing out to you how we can do some of the searches relative to a particular area, and this is in diabetes. And so we drill down for a particular filter, and we, within the New Hampshire multi-stakeholder group, really focus on the age between 18 and 75. And this becomes critical for folks to be able to do this sort of searching of your data in order to come up with information specific to where you want to try to make some changes. And to set your information gathering up before you start the work rather than after, a much stronger research model when you do it in those regards, in those methods. This, I hope, serves as a touch of humor for all of you in terms of the NCQA process. This is a piece of that entire worksheet to let you, just to remind you of the complexity of what you will be doing. But when you go about this one step at a time, this is certainly doable. But recognize if you try to look at it in this view from 60,000 feet, you will be overwhelmed, and try to avoid that. So the next few slides are some basics in terms of some of the successes that we've had in gathering some of the data over the last few years. And each of these categories that you'll see written across the bottom of the screen are those basic areas. As you'll see, the time period height was something that we said, oh, we're not getting that, and obviously we improved. And my slides are not quite showing that I'm able to see this as well as I'd like to, and I'm wondering.
I can't see it either. Oh, there you go.
Oh, there we go. I just switched that a little bit. So each of these are still giving you the same basic information in terms of we're scoring very well consistently over those 3 time frames. Now, here's the great one, the great learning piece for us, in that, yeah, it looks good, and oops, what's the big question mark? And that is a perfect example of what Don Berwick talked about this past week in his keynote for the NCQA Health Policy Conference on the journey. The journey not just for the patient in healthcare, but also the clinicians and the institution. And what we saw in going through this with our EMR was not graphing adult growth chart information. We could collect the information, we could calculate it, but it wasn't graphing it in any way, and so therefore it wasn't really usable. And we're happy to recognize that that will easily be something we can see come January when we convert. But without asking the question and setting it up ahead of time, you're not going to get that information until down the road when you're doing any of your electronic record data collections. And having that question for yourselves beforehand can be incredibly helpful to speed up that learning curve. Here again, treatment plans, one of, I would say, most important learning pieces for us in terms of setting up a plan in which you're able to follow through in the chronic disease management, which is able to use something like Prochaska's model or whichever behavior change that you're doing, but it's a printable piece that you use with your patients. And we are certainly seeking to be at the 100% level. A little bit of evaluation here that we did relative to diabetes aspects as well as tetanus in the recent days, and my screen is being blocked again here. I'm not sure what's up. The data that we had that we were happy with was looking at the A1Cs, comparing 08 with this next slide for 2010. In that we continue to show that we're learning from what we're doing. And the small little pieces that we're able to do continue to show that information. Recognize we are a small clinic, and so these numbers have to be taken somewhat with a grain of salt. You wouldn't want a statistician to make fun of the numbers with our p-values, which I'm obviously not going to print because they're somewhat useless because of the small numbers that we have. Looking at our A1Cs over the last month, as well as the LDL, certainly we're doing the measurements well within expectations. There again, serum creatinine is a wonderful measure to be looking in terms of quality for the patient with hypertension. And one of the fascinating pieces that we saw was what were considered the cost for the patient versus the expectations. And so to me, this is one small example of the medical home model where we can say, oh, well, geez, maybe the medical home model really is helping because there's a $35 difference between the actual cost versus the expected cost. And please don't take this as an absolute piece of quality data because we're such a small practice, but it certainly raises a question for all of us of something positive. Lessons learned. Most fascinating conversation with the team looking at potential improvements for all to consider. And I'll leave those for you for your leisure. My goal for each of you is to consider lessons that you would like to have and have those printed out for yourself that they continue to be something that you focus on. And for us, the big piece that we'll be moving forward is trying to measure engagement as well as the patient experience. Not only does it fit the nursing model, but it also fits very much of what Institute for Health Improvement and others are looking at in order to confirm the improvements in healthcare and cost for overall patient care. And with that, I would like to just give a final to our founder, Katie Kidder, and all that she did to help get the clinic started, to pave the way for many others across New Hampshire and the country as nurse practitioners, as we achieved level 3 on the NCQA patient-centered medical home process. To that, welcome any questions, and eventually we're going to do that polling as well.
Okay, Sean, thank you very much. One question has come in, which was, is there an estimate of what percentage of rural patients are left out of the patient-centered medical home due to lack of coverage in their area, what the term broadband coverage?
I don't have that number. I heard that discussed at the National Health Policy Conference, and I think that's something we should be able to get sent out through NCQA from that last conference.
Okay. Before we draw a quick close, I wanted to point out again that our next webinar is January 13th at 1 o'clock Eastern Time. It will be David Kibbe, who's Senior Advisor for the American Academy of Family Physicians, and the title of his talk will be HIT Functional Requirements for the Medical Homes. I think we've run out of time, so that we won't circle back for a panel discussion. I'd like to thank all three of our presenters and all who've stuck on the phone to the very end. And I look forward to seeing you next month. Thank you.
Thanks so much.